original ESMO consensus guideline, the majority of them are applicable to Asian population. However, some statement or some editing was made because the considering Asian ethnicity. The new Pan-Asian guideline fully cover Asian ethnicity. Now the current status, situation among the Asian country, the outstandingly differ, and because the approval status as well as reimbursement status is different country by country. Now the current situation is not science-based medicine in Asia, more reimbursement-based medicine. So it's not a good situation. The patient should be treated by science-based evidence. So I guess this guideline have a strong power to the regulator as policy proposal.
Well, if we talk about these new ESMO Asia guidelines, we have to recap that it is clearly an Asian guideline, meaning it's an Asian adaptation of the European guideline. But at the same time, it is an update of the European guideline because it was an inter-review and a consensus meeting between European and Asian experts. So therefore, we have a guideline which is now, let's say, valid for Asia and Europe. And there were some new points which were also entering this guideline. The first is clearly the Asian view on European recommendation, but the second is the new data about tumor-sidedness, we'll say left-sided tumor, right-sided primary tumor, and how this interacts with the treatment recommendation. We have now a number of trials which have been analyzing retrospectively the outcome of left-sided and right-sided, and most interestingly, most of these data are referring to all anti-EGF receptor antibody-containing trials, be it in first line and second line, be it cetuximab or be it panitumumab. And the totality of this data has helped us to understand where the benefits are from the anti-EGF receptor antibodies, so which patient groups do better when they are treated with anti-EGF receptor antibodies.
Well, the ESMO Asian guidelines are I think, the correct guidelines for the moment. And they say that we should give for the left-sided colon cancer cetuximab as first line. It was shown by the studies, two big studies, the FIRE and the CLGB studies, that cetuximab is the best treatment for left-sided colon cancer. It gives survival benefit, and it's a significant survival benefit. Therefore, there is no question, actually, that it should be given for the left-sided colon cancer.
So if we come to the actual recommendation, we have seen that, and I think the most relevant is the first-line treatment decision-making, that we have a very clear picture for the benefit of anti-EGF receptor antibodies in first-line RAS wild-type left-sided primaries. And here, namely cetuximab, and most of the data comes from cetuximab, has clearly shown that cetuximab should be, let's say, seen as the standard of care for left-sided RAS wild-type patients. If we then look specifically on the differences between cetuximab-containing trials and panitumumab-containing trials, we can clearly acknowledge that we have by far more cetuximab-containing trials than panitumumab-containing trials. Also, the trials which are the most important for the level of evidence and leading to this class 1A level of evidence is clearly the comparison, which is the most relevant question, between cetuximab and bevacizumab when it comes to selection of first-line treatments.
Well, on the right side, bevacizumab seems to be, according to these guidelines, the first preference for the treatment, although cetuximab can be given as well. Now, in the other guidelines, it's only bevacizumab that should be given. But it's quite strange. It was not shown that bevacizumab is better than cetuximab on the right side, it is not statistically significant. What we know is that cetuximab is not better than chemotherapy only. If we add it to chemotherapy, it's not better than chemotherapy only. Bevacizumab also is just a little bit better than cetuximab, but not statistically significant. So it's strange that we eliminate somehow the cetuximab and we add the bevacizumab, but it is because it is the default treatment, not because this is something that is was shown that is statistically significant. It's not evidence-based medicine. It's just our feeling, but it's not evidence-based medicine.
For right-sided tumors, the recommendations are to use more bevacizumab combination with chemotherapy, but there remains some patients that could benefit from anti-EGFR treatment. It is patients where we are needed rapid response to treatment, and in these specific patients where we need rapid and profound response to treatment, we have to give to this patient combination of chemotherapy plus anti-EGFR. And in the future, something that is ongoing, and we got some data for that, is combination of triplet chemotherapy plus anti-EGFR agents that seems to give very interesting results in terms of response rate and median progression-free survival.
Well, up to now, for the ESMO guidelines, sightness officially have not been included yet. It's going to be included probably by the end of this year, and then we will have a very clear guideline telling us, do the RAS test for the RAS wild type, left-sided, go to anti-EGFR, right-sided tumors. You probably have a choice between anti-EGFR or bevacizumab. And for the RAS wild type mutant patients, it's very clear. Here you have to use the bevacizumab combinations. When we look at the NCCN guidelines, it's kind of interesting from a European point of view that even though the data on left-sided tumors, as we have talked about, is way stronger in favor of the anti-EGFR treatment than on right-sided tumors for the VEGF-based treatment or anti-VEGF-based treatment, the recommendations do not reflect this. Basically, they say on left side you can use both, okay, even though bevacizumab combinations have retrospectively shown to be inferior to the anti-EGFR regimens, but they would say you can use both. On the right side, it is more like do not use anti-EGFR, even though when we look at the PFS and overall survival differences, they are way smaller than what we would see on the left-sided tumors. So this is kind of a hassle we have for the NCCN guidelines at this point. It probably has to do something with the insurance system in the US. So they would like to allow bevacizumab also on left-sided tumors to get reimbursed. That's at least what our American colleagues would tell us, and that's why they put this into those guidelines. They are reviewed several times a year, so we will see how they will evolve.
We have several guidelines which can help us making decision. ESMO guidelines, now ESMO Asia guidelines. As I was saying before, this is not an Asian guideline, this is a European guideline which was also now consented in Asia. So therefore it's also relevant and extremely relevant for European decision makers. And of course also the NCCN guidelines from the United States. I do see a bit of a difference between the ESMO guidelines, be it Asia or ESMO, the original guidelines, and NCCN, because ESMO guidelines try to make physicians understand what is behind this recommendation and really try to give a bit of a guidance, what should be preferably used in which situation. Whereas the NCCN guidelines rather show the totality of options which are available, which may be reimbursed, which are right somehow to treat, but I think a bit more guidance stands behind these ESMO guidelines formats.